a urologist that I first met when he was a resident and I was an attending up at Einstein. And I know he's very, very good urologist. And he has just joined NYPQ as an attending urologist. And we asked him to come down to speak to us about something that we really all should know about, because if you haven't got a problem with it now, you're going to have one sooner or later. You should live so long. Dr. Moss.
Thank you. Hello, everybody. Thank you, Dr. Mel, for inviting me, and pleasure to be here. And we talked about the topic, Dr. Bright and I talked about the topic being prostate and voiding dysfunction. And we'll begin with prostate and then go into, say, voiding dysfunction. And if necessary, feel free, as I'm talking, just raise your hand or just start interrupting me and give the question you have. And also at the end, we can answer any other additional questions. And if you have a question a urologic question other than what we talked of prostate avoiding dysfunction, I will answer that too. So we can then open it up to all of urology questions. So to begin with, the urinary tract is composed of, we all have two kidneys, a tube that leaves each kidney and goes to one bladder that we have, and then to the male sexual organs, and to the female beyond the bladder. In the men are the male sexual organs, penis, testicles, scrotum, prostate, and in a woman, the urethra. So that's the structures that encompass urology. So the prostate's function is to make the fluid as nutrition for the sperm. There's no other function for the prostate other than making that fluid, and at the appropriate time, the release of that fluid. So it's a gland that secretes this fluid in a man. Now, the prostate starts growing in all men after the age of 35. So usually the first thing, a man sits down in the office and tells me, oh, I just went to the big urologist and he told me I had an enlarged prostate. We know every man over the age of 35 has an enlarged prostate compared to what his prostate was when he was 35 or 40. So every man has this enlargement. Amazingly, miraculously, most of this enlargement for a man's active life up to, say, 80, it just enlarges and a man never sees a urologist. Okay. And amazing, of all the organs in the body, the prostate is the only organ in the body where doubles, triples, becomes 4 times the size, 5 times the size. Okay? And it's a silent enlargement, and we have no other organ that grows so much and can be not bothersome to the patient at all. So what can affect this prostate as a man gets older? Every man's prostate enlarges. Some people can get an infection in their prostate. Some people can get cancer of the prostate. And we know that every man develops prostate cancer and has prostate cancer by the time they're 80. It's part of aging of the prostate. So the term we use is a man dies with prostate cancer, not because of it. And that statement, that knowledge that we all are getting prostate cancer, some people feel, why are you screening and looking for people who have prostate cancer? You know you're going to find it. Okay, Why look for this? It may not be an issue for most men, and it isn't a problem in most men. And to put people through screening and looking for this cancer, you can cause harm to those people with the PSA blood testing. They're anxious, they're nervous, then you're doing biopsies and they're having problem. Prostate cancer is a serious illness. All cancers are and have to be followed. And prostate cancer, if a man develops it in their 50s, has to be treated, and in their 60s, and there's a question about how much treatment and how much discovery of this cancer in a man who's in his 70s, because our life expectancy is 79, 80. So to look for something and start doing all sorts of tests and treatment and evaluation in a man who's 74, 75, 76, sometimes the treatment, the investigations are worse than the disease. And we could just talk about this issue with prostate cancer discovery and screening from now till tomorrow morning. There are reasons to do screening and looking and treatment, but in summary about prostate cancer for the moment, men do develop life-threatening prostate cancer. Fortunately, we have excellent medications that can slow the disease down or cure the disease, including surgery and radiation. So I'm not saying not to treat the disease and not to look for it, but we have to be, when we are, as urologists, we are continually trying to analyze who needs the PSA testing, who needs the prostate biopsy, because the prostate biopsy can have problems.
So you say that all men have an enlarged prostate and they won't even really know it, and all men will get the prostate cancer and they won't know it unless there was a test?
All men will develop and will have enlargement of the prostate, silent disease, never see a urologist. Some men will never see a urologist. Then there's another group of men who will have to see a urologist because the way the prostate enlarges, and whether it's the middle section versus the outer section, where the enlargement occurs can block the flow of urine. Okay, so we can't predict when a man is 40 years of age where his prostate will grow, the inner portion, like the segments of an orange, or looking at an apple, the inside core, where you core out the inside of an apple. We don't know ahead of time where this enlargement will happen. In the back portion of the prostate, which we do with a rectal exam, or the inner portion. So a man may have blood in his urine, he may have a urinary tract infection, he may have slow stream, a weak stream, a hesitancy when he urinates. These are all signs of prostate issues, problems, enlargement, obstruction to the outflow. Because the prostate Hashem put the prostate in the wrong location. Because the prostate is at the base of the bladder. So all the urine has to go through the middle of the prostate. So that's the issue. If that middle channel gets blocked by the portions, the lobes, the segments of the prostate, then the man has trouble urinating.
So my question is, if he would never be tested for the cancer, would he even know that he has it?
Correct.
Prostate, I understand about the enlargement, but now the cancer part, you're saying there's questions about whether to be tested.
Absolutely.
If he's not tested, would he even know that he has the cancer?
At age 60, first of all, he will never, the man, no. The cancer cells don't flash a sign to the man, oh, you have prostate cancer. So the tip-off that a man has prostate cancer, most common tip-off would be that the man says, maybe I'm losing weight, maybe I have bone pain, maybe I have difficulty urinating, maybe he went for blood tests, and some of the blood test abnormalities, anemia, so weakening of the bones, he can put out different chemicals. So through blood testing we can find out, through infected urine we can find out, or it can suggest that maybe he has prostate cancer. Yes, often a person will have a bone abnormality because prostate has a tendency that it spreads to the bones as one of its first sites. And all cancers have different patterns. And in prostate, the most common spreading point, first point it goes to, are the bones in the back. And but a 50, 60-year-old man will not know, unless he has some of what we call the signs. And in medicine, signs are objective things, blood abnormalities, like I said, X-ray abnormalities. Symptoms are how you feel. Well, the prostate cancer is not going to really cause a symptom until a man has very extensive disease that he feels weak and tired, and he's from the anemia, say. So, fortunately, with prostate cancer, as I said, we have, as you see advertised on TV, all this good, very effective radiation therapy, surgery, and medications. And what's it? Cyberknife. Now, one of when someone comes in and they have a spread of their prostate cancer, right? We found out that the prostate cancer has left the prostate and has gone either to these cotton ball structures we have in the body called lymph nodes, or it's gone to the bones, say. Well, our first type of therapy is what we call hormone therapy for prostate cancer. And the Nobel Prize in Medicine was won by two physicians 60 years ago for finding that relationship of prostate cancer cells requiring the male hormone testosterone for their growth. So when we treat people for metastatic prostate cancer, that's our first form of treatment, is using medication to block testosterone. So even with all the advances, what I'm bringing out, all the advances we talk about in healthcare, in medicine, in urology, we still go back to something that these two Nobel Prize winners discovered, that relationship. So, fortunately, the majority of the prostate issues that we deal with in urology are really from the benign, not cancerous enlargement that all men have. And even a man who has prostate cancer in his 80s or 90s, and he comes in and he says he can't urinate. Well, I'm not interested in his prostate cancer if he's 80 or 90. Okay, we're not going to do cyberknife or radiation we just want to make the man be able to urinate because he came in the office for that. And again, we always have to balance the risk benefits. We're not going to put an 80, 90-year-old person, hopefully, through a 3-hour radical prostatectomy to remove it. At that point, we just want to make him urinate, and maybe we have to use hormone therapy. So prostate enlargement is a common issue that men come to the office because they notice. And what do they notice? They don't say, gee, I have prostate enlargement. They say, gee, I'm standing there in the bathroom and the urine is very, very slow, hesitancy. They may not empty all the urine. So, of course, they have to go back 15 minutes, an hour, 2 hours later, and they're up all night long. There's other reasons why people get up at night to urinate, but it may be because they're not effectively emptying all of the urine in the bladder. And whether it's a man or a woman, as we'll talk about bladder dysfunction, the bladder was designed to hold urine, and when you do urinate, man or woman, you evacuate 90% or more of all the urine in the bladder. And if you don't do 70, 80, 90%, you'll be back a few minutes later, half hour, an hour, to finish the job or to get the remaining urine out. So this is the common issue. Now, if the urine sits in the bladder, you didn't empty the bladder because of this prostate enlargement, that urine can become infected. Bacteria find that warm urine that has sugar in it, and that also particles can stick together and you can make a bladder stone. Okay, and you're not going to urinate out a bladder stone, but the bladder stone can lead to recurrent infections and it can lead to blood in the urine because it scratches the wall of the bladder. Another malady that affects the prostate is infection or inflammation. Okay, it's hard for us to say, is there an infection in the prostate, because we really don't purposely put a needle into the prostate to draw out the bacteria or the pus that's in the infected fluid, okay? But we surmise that there's an infection in the prostate because the man came in with temperature and he's got some pain in his lower abdomen. He has difficulty urinating. He may be 30, he may be 40, usually in that age range. And when we do a rectal exam very gently, the prostate is more tender than it would be normally in just plain enlargement of the prostate. So people get a prostatitis, and we have to give them a week of antibiotics and warm baths, limit alcohol, spicy foods, and coffee. And that's, for some people, that's a recurrent problem of prostatitis. And they're very uncomfortable intermittently from that. And stress, it can be related to stress. So the prostate can develop an infectious inflammation. It can develop cancer, and in all men, it develops enlargement. Another thought that I want to share with you, when we do make a diagnosis of prostate cancer, so a man had a blood test done for screening and looking for prostate cancer. It was elevated. The medical doctor said, go to the urologist. The urologist in the office did a 15-minute biopsy of the prostate and now shares with the patient what could the biopsy show. It only could show really three things. No cancer. Okay. So you tell the patient, tell the patient, I did the biopsy, no cancer, but I only sampled the prostate. I took 12 pieces. Okay, maybe the 13th or the 15th or the 17th would have had cancer. So the man says, so we say to the patient, come back in a year, we'll follow the PSA. If the PSA goes up further, you'll do another biopsy. Patient says, what, are you kidding me? You think I'm coming back for this again? So we monitor the patient. Another scenario could be elevated PSA, you did the biopsy, you tell the patient, I have good news and bad news. The bad news is you have prostate cancer. The good news is you have very small amount of prostate cancer. Maybe 1 or 2 of the little pieces that we took out had the cancer. Not only did only 1 or 2 pieces have the cancer, the type of cells of the cancer were not very aggressive cells. Therefore, you don't need any treatment. So that's the good story. So the man says, what? I had the biopsy. I landed up in the emergency room. I was bleeding. I couldn't urinate. I had antibiotics. And now you're telling me all of that, and you're not even treating my cancer? So you have to explain that this is a very small amount of your prostate had the cancer in it. The third patient is the one that you have to tell the person, listen, I did the biopsy. All the specimens had cancer in it, and it was a high-grade, bad form of cancer. And yes, you need CyberKnife, or you need radiation therapy, or you need radical surgery, and sometimes you need after the surgery, you need even radiation after the surgery. And that's the difficult problem in urology, that we're always looking for that patient who has the aggressive, bad form of prostate cancer that often is difficult to treat with whatever modalities we have. 2 things I just want to share with you about, one about prostate cancer, one about cancers in general. Prostate cancer, when we made that diagnosis, last week in the office and told a man you had prostate cancer, sometimes in the conversation, they'll say, gee, I wish I came in here 2 weeks ago, a month ago, 6 months ago. Doesn't matter. By the time the PSA is elevated, or we feel on rectal exam a nodule. The man has had prostate cancer 5 to 10 years. It begins as a single cell. So till that cell grows into hundreds and thousands of cells, enough that we could feel it with our finger, or makes enough of this protein, that's the PSA, it's a type of protein, the man has had the cancer for 5 or 10 years silently, like you were saying, man doesn't know it, so they've had it for 5 or 10 years. The other thing, as I mentioned about when we did the biopsy, you look at the biopsy report and it says you did usually about 10 to 12 specimens you took out from the prostate, and it tells you it's graded, say 2 being the best and 10 being the worst. That's the cell type. Now, all cancers in the body, the most important feature to understand prognosis, the future for that patient, is what type of prostate or bladder cancer or kidney cancer or breast cancer or colon cancer. Is it an aggressive form? Is it well differentiated, poorly differentiated? That's the cell pattern, cell type. That's the fingerprint of the disease. So that is the most important feature, is what type of cells did your prostate cancer make? So, any questions yet about prostate? Yes?
What use have you made of the 4K system for diagnosing prostate cancer?
Okay. There's a blood test that the gentleman's talking about, 4K blood test. So, we're trying to select the people who truly need to have the biopsy done because there's a high chance that they may have prostate cancer. Because most of the time when we would do a biopsy, if we just say, oh, your PSA is elevated, come in tomorrow, we're going to do a biopsy. Say you had 10 people like that. PSA is elevated, go, let's do a biopsy. Well, 80% of the time, the biopsies are negative. Why are they negative? They're negative because the man has no cancer in his prostate, could be, or we just missed the spot because we only took 12 pieces and the 13th piece. Okay, so it's falsely negative, and that's when we say come back in a year. Okay, so this is part of the problem and issue with doing PSA testing. So in trying to say who really needs the biopsy, so we don't do 80% of the time biopsies that come back no cancer, but of course, as I said earlier, I mean, if 80% of men age 80 have cancer, a man in his 70s and 60s, they have cancer someplace, a small amount that missed it on the biopsy. So we send another type of blood test from the arm, any time of day, you don't have to fast, and that's analyzed for different other types of protein in the prostate cancer that the cancer cells make. And they score that from 1 to 100, and less than 7.5, we tell a person, oh, your 4K score is less than 7.5. That means there's a low risk that you have aggressive cancer. And above 75 is a high risk. So that's saying that if we did a biopsy on you, as I said before, the type of cells that you have would be low-risk cancer cells or high-risk cancer cells. That's what they're saying. So a 4K score is helpful because I'd say to a patient, listen, your PSA is elevated, it's 5. So the man says, well, 5. Normal is up to 4. What's 5? You just told me you had a patient who could be 10, it could be 100, it could be 1,000. He's right. So 5 isn't so much, but I said, look, your 4K score said you have, that if we did a biopsy on you, there's a 75% chance you would have an aggressive form of prostate cancer, bad prostate cancer cells. So that gives us more conviction to suggest to the patient to have a prostate biopsy. Also, if the man comes back with a low risk, under 7.5, we say, listen, you may have prostate cancer. You're 68, you're 65, you're 60, there's a chance, we know it takes 5-10 years to grow, you have prostate cancer there, but it's not an aggressive form. Okay, so that's where the 4K score helps us figure out who should strongly get a biopsy. Okay, so let's talk about bladder issues, voiding issues. A little less threatening than talking about cancer for the whole evening. Okay, as I said earlier, we all have only one bladder. Bladder in a man or woman are pretty much similar. A bladder in a man is a little thicker walled because the bladder in a man has to push the urine through this middle portion of the prostate, where female has a thin-walled bladder. But either way, in a man or woman, the bladder is supposed to store urine for 23 hours and 50 minutes. Just be a vessel to store. Okay, that was how it was designed. And only 3-4 times during the day and not at night. Okay, so obviously no one follows the plan, right? Okay, so we'll get into why no one follows the plan. But that was how God designed the bladder. Okay, that was and how did he design it that way? Because the bladder is elastic. It stretches out at very low pressure. So you could store urine, we would, all day long. There are people who say, listen, I don't want to use a bathroom wherever I go at work, wherever I am. I'm not using the bathroom. I'm going to go in the morning, and I'm going to not have too much fluid during the day. When I get home, I go to the bathroom. Okay. There are people who and it's not harmful. The bladder was made to store urine. Okay. So if they fluid restrict themselves, it's okay because there's a small amount. Say a tablespoon of urine you have to make an hour. So 30 cc, you have to make a tablespoon of urine. So if you made even 10 tablespoons, 20 tablespoons, and your bladder gets accustomed to storage. Now, just like a bladder gets accustomed to storage, a bladder gets accustomed to not storing the urine. And then the people come to the urologist. So when don't we store our urine? Some people have urinary frequency daytime. Other people have urinary frequency at night, nocturia. Some people are both. Okay. And you know who you are. Now, this is a real lifestyle annoying issue. You're not going to develop any diseases from it. You're not going to develop stones from it. It's just a nuisance problem and embarrassing, annoying, and disruptive. So we'll get to the treatment in a moment. So just more characteristics about the bladder. So the bladder is elastic. It's a muscle. It's supposed to store urine, and that muscle then at the right time pushes the urine out. And when it pushes the urine out, just like a jar has a neck, there's a neck, a sphincter to the bladder, and miraculously the neck, the sphincter relaxes when the bladder pushes the urine out. Okay. So you need these two things, two different things. Something is contracting, pushing, something is relaxing. And you need this functionality going on to be able, man or woman, to effectively empty the bladder. Okay. So there are diseases, neurologic diseases, metabolic diseases, diabetes, metabolic, neurologic diseases, could be multiple sclerosis or any neurologic disease, stroke, Parkinson's disease, can interfere with the nerves that work on the bladder and work on the sphincter. And this is then people have to come to the urologist. Because a person won't complain and will be hesitant to come to the urologist and say, listen, I'm a type of person, I don't urinate much, maybe once during the day, once or twice during the day, or just once during the day. And they have these large bladders, just like people have these large colons and they just don't move their bowels that often. So that's one problem that people may not come to the urologist for, or don't come to the urologist. But what they do come to the urologist for, if they're wet all the time, frequent urination, which then can be incontinence, that they just lose the urine, that it just leaks out for a variety of reasons, that they leak out the urine, and then we use medication to control the bladder. With regard to what I just said, that when we discuss whether it's prostate cancer or prostate enlargement or bladder or any dysfunction in the human body, we as physicians, we learn either in a classroom or in a book or just learn by being in practice and seeing patients, we observe there's what we call the natural history to the disease, whether it's coronary artery disease, whatever disease it is. So this is how we, as physicians, understand the disease. It's not that it's just this urinary frequency, it's a spectrum. Prostate, cancer, where is that patient in the spectrum of the disease? Do they just have the urinary frequency? Okay. Other people are more severely affected, that their nerves don't relax at night when the person's sleeping. So those bladder nerves are still making the person get up 5-6 times a night, or the person has trained their nerves that the frequency that they have during the day, they just can't shut it off at night. Okay. So this is part of this frequency, and so the natural history of overactive bladder, we can call it neurogenic bladder dysfunction is daytime frequency, mild, then it gets more severe, then they get nocturia, getting up during the night, and then they develop urgency to void, that they can't get to the bathroom in time. And what is urgency? Then you're talking, well, it's urgency, yes, but I'm losing the urine. So you call it urgency or call it incontinence, whichever one the person wants to call it, but this is part of this spectrum of voiding dysfunction. So we, as urologists, figure out where the patient is, what's the prognosis and where they're going, and how to interrupt, because we know what, if they don't come to the urologist, they may stay where they are, or they may progress to a worse form of the problem. So understanding that concept of the natural history of a disease is what we as physicians hopefully bring to the exam room as we're talking to the patient with whatever organ we're talking about.
So can you retrain?
Okay.
Instead of using medications, can you do it like just try
Yes.
a different
So
way of doing it?
now we'll discuss the treatment for bladder issues. So we have a few medications, when I say few, 5 medications. They all work the same, they're similar. Some are generic, some are branded. There have been some improvements, so the branded products may be a little bit more effective and maybe have less side effects in a given patient. Okay, ahead of time you don't know which patient's gonna have some of the mild side effects, annoying side effects. So we have medication to use. So you're ready to tell a person, listen, here's the pill, take it morning or night or whatever, use medication. Some people say, listen, I don't want any medication. I don't like to take pills. Okay, so then we go back to something, in addition to medication, we instruct them to do what we call timed voiding. I said, look, you just urinated, you left the specimen in the office here. You just urinated, it's 8 o'clock. You came here today to the office, you've had this problem for 5 years, 10 years, but you decided to come at 5 o'clock tonight with your problem. That's another interesting question to ask. What was the motivation? That all of a sudden after 5-10 years, I want to come here. So listen, this bladder dysfunction is not like a urinary tract infection or hypertension or elevated blood sugar. You take a pill today, and in an hour or two, the blood pressure's going down, the sugar goes down, the antibiotic starts working. So this is you have to explain to the person, lower your expectations. We're going to use timed voiding, that the first week, you go every hour. If you can hold it longer, you hold it longer, but no more frequently than every hour. Second week, every hour and 15 minutes. Third week, every hour, 30 minutes. So time voiding, increasing those durations, okay? That, of course, have the normal amount of fluid, And at night, no fluids 2 hours before bedtime. Now, there's some people who say, I have tremendous frequency during the day. They don't have a problem at night, so you don't have to address the night issue.
Yeah, I'm sorry, how much time before you go?
2 hours before, no fluids 2 hours before bedtime. So we have medication to use. Medication usually probably is effective in, say, 75% of patients. We may have to start with one medication, increase the dose. We may have to add a second medication, so a morning pill and an evening pill. And there's 5 different types of medication. They work on different types of nerves within the bladder wall. So that's why combined therapy we do. And again, we can start with the generics because they're less expensive and they're very effective also. And if the medication fails, in conjunction with the medication, I always say timed voiding. And this problem of bladder dysfunction, urinary frequency, voiding dysfunction, the patient has to be their own doctor. Again, it's not like hypertension, or like I said, diabetes, that take a pill and forget about the disease. They have to treat themselves and have to spend the time, as we're talking here, this concept, time voiding. If the medication doesn't work, then we do something that's very, very effective, minimally invasive, what we call sacral nerve modulation. The sacral nerves come out of the lower back, in the sacrum, below your spinal column. There's another group of bones called the sacrum. Nerves to the bladder come out of the sacrum. So in the office, we can put in a little wire through the skin to those sacral nerves. We know where they come out, into those nerves, and then run a wire underneath the skin and implant, like a heart pacemaker, we implant a pacemaker in the side wall of the abdomen to modulate and control the nerves to the bladder, because this pacemaker releases an impulse for the nerve, when the nerve should relax and when it should work. Okay, so we have that sacral nerve modulation. So that's a procedure we can offer the patient for this. Another type of procedure is we can use Botox, right, which relaxes nerves. We inject in multiple sites in the bladder. In the office, a few minutes, we inject maybe 10, 15 different sites in the bladder. Again, giving the Botox to relax the nerves of the bladder. Because a person who has this urinary frequency and getting up at night, one or both of them, or urgency to void, their bladder, if we took their bladder out and looked at the bladder, it looks like everybody else's bladder, because this is a nerve problem. It's not a bladder problem of the muscle of the bladder. It's the nerves that are innervating inside the wall of the bladder, which come from the sacrum and then go up the spinal column. That is the issue. So that's a common problem that we see in the office is overactive. We can use the term overactive bladder. That's a layman's term that didn't exist 40, 50 years ago, but we could use that because everybody kind of understands when we say overactive. We used to call it a spastic bladder, a neurogenic bladder, because again, it's nerve issue. Unstable bladder is another term, but this is all about nerves affecting the bladder. And you can imagine how many people have neurologic diseases, as we talked about, strokes, MS, Alzheimer's, Parkinson's disease, who eventually have to see a urologist because those nerves are affected by the disease. Other things about the bladder, voiding dysfunction, a person may say, I have a man will come in the office, or a woman, and say, listen, I have tremendous frequency of urination and urgency to go. Maybe they saw blood or not in the urine. So you do a sonogram of the man's bladder. So, he's 60 years of age. He's got tremendous frequency and urgency. So I know ahead of time. As I said before, he probably goes to the bathroom. He doesn't finish emptying his bladder. So, of course, a half hour later, he's got to go again. And he has this urge to go. And a woman may say the same thing. I'm going all the time. I'm going all the time. You do the sonogram in the office in 5 minutes, the bladder's empty. So what could it be? So there went what I said, that it's not his enlargement of his prostate. We know his prostate's enlarged. So he's got prostate enlargement because he's 60 years of age, so I know he has prostate enlargement. But as big as the prostate is, he's able to urinate. But where does this urgency and frequency and spasticity and maybe mild incontinence, this is the spectrum, the natural history, where does this come from? Often they can have a bladder cancer in the wall of the bladder, irritating the bladder nerves and muscle, giving him that frequency and urgency. And then that's another disease that we treat, bladder cancers. Okay, and it can present with frequency and urgency, urinary tract infection, and commonly with the man sees or woman sees blood in the urine from the tumor, the growth, or they may see microscopically, the doctor sends out a urine sample and saw extra red blood cells in the urine, and may come from this infection, neoplastic cancerous prostate, cancerous condition growing in the wall of the bladder. Okay, so that's another malady, disorder that we deal with. Bladder cancers, difficulty urinating, bladder stones, not really seen in women, seen in men, as I said earlier about prostate enlargement. And stones generally don't drop down from the kidney. If a stone drops from the kidney through the ureters into the bladder, the man urinates the stone out. Now, a man or a woman can have frequency and urgency and discomfort, and generally that isn't cancer, thank goodness, but it is in a urinary tract infection. Okay, so we deal with urinary tract infections, which are really, most of the time, 90% of the time, bladder infections, just the bladder. Rarely does a bladder infection, those bacteria go in reverse. Instead of going outside the body, they creep up that tube that I'm talking about, the ureter, up to the kidney. Of course, if they do, then a person has a bladder infection that went to the kidney, and they have a kidney infection in addition to it. So for a bladder infection, we use most often oral antibiotics, just oral antibiotics, for 5 or 7 days to eradicate the infection, and then we have to do some tests. Why did the person get an infection? Women can get bladder infections more commonly than men because of the anatomy. Again, the design wasn't very good, the architecture, that the urinary department is next to the vagina, next to the rectum. So this is a problem that bacteria find their way into the bladder. In a man, they can get bladder infections from not emptying all their urine out of their bladder, or from the growth in the bladder, the cancer, and in women, the growth in the bladder can give you, the bacteria find that growth, and then you get a urinary tract infection, plus the blood in the urine, and they have an underlying issue. Like I said, it's either a urinary tract infection in women, they may not empty well, a man may not empty well, could be the cancer, could be a bladder tumor. And women sometimes have bladder issues because the bladder may drop as a woman gets older. There's more pelvic relaxation of the support of the whole pelvis of the body, and the bladder may drop down in a woman, and when the bladder is not in the correct position, it doesn't function well to empty all the urine out of the bladder. So that covers about the majority of the prostate bladder issues. Do we want to talk about some other things in urology?
Just a general question on
Yes.
urinary frequency, not cancer related, comments concerning faith and Kegel exercises.
Okay, so urinary frequency. I didn't mention Kegel exercises because I generally don't mention that in the office either. Because Kegel exercises is Kegel. Kegel exercises is traditionally a gynecologist or obstetrician will mention to a woman, oh, you had the baby, or you have some urgency and frequency of urination, you're losing urine, do these exercises, contract your anal sphincter, like you're holding onto a bowel movement. So when you're standing up at a light, at an elevator, you inside contract your anal sphincter. You do that for, say, 20 seconds, do it once an hour. Do it for a month, come back to the office. Minimally effective, because the anal sphincter, when you're doing that, you are unknowingly contracting that neck of the jar that I talked about, which is the bladder neck urinary sphincter. So you're hopefully increasing the tone of the urinary sphincter while you're increasing the tone of your anal sphincter. So that's the Kegel exercises. And a woman only has that one bladder neck sphincter. So they're more prone to have loss of urinary incontinence than a man, because a man has two sphincters. A man has the sphincter at the bladder neck, like the neck of a jar, but beyond the prostate is another sphincter, we call the external sphincter, and that's a second sphincter a man has to hold on to the urine. And some men will come to the office, a common complaint, and say, listen, I just went to the bathroom, and when I leave the bathroom, there's urine dripping, out, and I have to stand and wait. No matter what I do, there's more urine and more urine. Well, we talked a little bit, this is part of the coordination between the sphincters and the bladder. How to begin the urination, the sphincters have to relax a second before the bladder pushes. When a man finishes urination, the sphincters have to stop and the bladder has to relax. And this coordination has to be sometimes retrained in a man, and giving them different exercises to help tighten the urinary sphincter. And what we tell the man to do is, as you urinate, it takes about 3 seconds till the stream develops, the full stream. In the first urination in the morning, you have the urine from the whole night. Let the urine come out. 3 seconds later, stop it. Voluntarily contract that sphincter. And then for 2 or 3 seconds, and then relax the sphincter. So this is sphincter strengthening, and that carries over to when they're using the bathroom and urinating. So Kegel exercises really are not that effective. There's nothing wrong, they're not dangerous. We try that, especially in conjunction with the timed voiding, keeping a voiding diary, and really the person has to be very motivated and will do it. And some people say, listen, I don't want medication. Other people say, no, I'll go for the whole program. Give me the medication, let me do the timed voiding, let me do the Kegel exercises, because I don't want this situation. And usually, how do I know it's effective? Because the majority of the patients who I do this for, they come back in 3 or 6 months for renewal of the medication. And maybe I have to raise it a little bit, or maybe say, no, it's fine now. Maybe I get up only once, or I don't get up at all, and they're damn fine. Yes?
What about stones?
Stone disease. Okay, so stone disease is a common condition, men and women all over the United States, all over the world, that in some patients it's genetic, hereditary. The family has a history of stone disease. It's rare that it's anything related to diet, but some intestinal disorders, those people can manufacture stones. But kidney stones, are manufactured, made in the kidney, because there's either too much calcium or too much uric acid, or it could have been a kidney infection that made it infectious stones. So stones are very common in people, and often when we do a sonogram for some other reason, an abdominal sonogram for abdominal discomfort or stomach issue, that the report will say, oh, the person has a kidney stone. You'll tell a person I have a kidney stone. They say, oh yeah, I knew about that for years and years and years. So one person may have a stone small in size, say under a centimeter, a small stone size of a pea, 4 millimeter, 5 millimeter, doesn't bother them at all. They may have 5, 10 of them. Another person can have one stone and be in the emergency room and have all sorts of problems. So stone disease needs, as most issues in medicine, needs a lot of care and thought, because it depends on the size of the stone, the location of the stone, whether the other kidney has stones, with regard to the treatment. Because again, some people you say, and a person will tell you, I've had this stone for, what do you tell me I need surgery tomorrow? I've had this stone for 5, 10, 20 years, it never bothered me. Correct. That's awful, but you don't know what tomorrow holds. And a person must say, listen, I travel all over the world, I'm leaving America, I don't want to be stuck with this stone and wind up in some hospital, I want the stone removed. So there's all different reasons to remove the stones, but having a stone in a kidney is not the issue. It's if the stone tries to leave the kidney, okay, and go down that tube that I'm talking about, the ureter, that's the problem. Because again, the design wasn't good. That tube is only 4 to 5 millimeters, okay? So the stone is not going to make it down the tube. And that's when intervention has to be done, because when a person has a 6, 8, 10 millimeter, whatever size stone, if it's more than 4, 5, 6 millimeters, the higher it is, the less chance it's going to make it down the tube. And again, the design here wasn't that good, because the tube gets narrower as it goes down to the bladder. And by the time the tube gets down to the bladder, the opening in the bladder is maybe 1 or 2 or 3 millimeters. It opens like this, like the mouth of a fish, the orifice in the bladder. So again, persons in the emergency room, the stone gets lodged in the tube, and that because it's lodged in this vertical tube that we have, the kidney woman has pain in the kidney because the urine can't go. There's pressure. You built up pressure. The pressure is water pressure, it's urine, and it can't go down. And then some type of intervention, surgery that has to be done. It's only a small 10% of stones are uric acid related, sometimes to gout, that we can try medication, but the medication doesn't work overnight, and a woman's in severe pain from a stone. As we talked earlier just about the natural history of the disease, so the same thing. Is it a 4 millimeter stone? Where is it in the kidney? What's the likelihood of it going down the kidney? Is the person a diabetic? Are they going to get an infection with high fever and chills of 103, shaking chills, and then drop their blood pressure, have all sorts of sepsis of bacteria throughout their body? So you can have a small stone, big problems. You can have a big stone, very few problems. So for the urologist standing there in the emergency room, seeing the patient, seeing what the white blood count is, seeing all these factors, do they have another kidney? Is it a well-functioning kidney? So this is where we intervene and understand. And so stone disease, because of the chance of obstructing that one kidney, we don't want people to be walking around with blocked kidneys. Yes, and then I'll click.
Would a large kidney stone, large calcium oxalate